The current literature tells us that less than 5% of the time when you place an NG tube down, it might go into the lungs. But actually, when you put a CCD chip on the end of an NG tube, you find that that can happen up to 50% of the time. This is a very real risk. And that these nurses really do need more education, training and support that goes beyond what's currently available. Putting a tube into the stomach is not without risks, and it's something that actually has been underestimated over a long period of time, but I think now we are starting to realise the very real risks that exist with placing an NG tube. If we had a foolproof method of testing, then it would be relatively straightforward, but we don't. And I think that's also slightly under-recognised as to how inaccurate they can be, or where the flaws lie.
There are currently two acceptable methods for testing the position of a nasogastric tube. The first line test is the pH of the aspirate. That means that you take a little piece of the fluid out of the tubing and check the pH value of it on a pH strip. The pH from the stomach should be acidic, so by knowing the pH value you can have some degree of certainty of knowing where the tube was inserted. The other method that we can use is X-ray. So that is the second line method if the pH method has failed, but unfortunately X-rays do not always accurately show the position of the tube, and sometimes they can be misinterpreted, even by quite senior staff. Years ago, I became interested in how accurate were the pH strips that we use in clinical practice. We're making a very important clinical decision based on sometimes a very subtle colour change. So if you're not able to tell the colour change accurately, or the colour change is very difficult to determine, you could potentially make the wrong decision. And that wrong decision could actually be very damaging to the patient and could actually result in their death. So I did some in vitro research in which I enlisted 13 volunteers to colour match from an international colour reference system what the colours were on the pH values that we used to make these clinical decisions. At 5.5, the 13 raters identified 12 different colours. We do need more emphasis placed on the methods available to us to assess the tube tip position so that it can legitimately be a never event. At the moment, with the inherent inaccuracies of the methods that we have available to us, it is almost an unrealistic expectation to say it's a never event.
Often it's perceived that taking a chest X-ray is the gold standard, but actually when you start to look into it, errors happen and there's a misinterpretation of even a chest X-ray that happens. So even that is thought to be a gold standard is not perfect.
Becky's just asked me to talk to you about NG tube placement checks.
So there is a pressure often from doctors to nurses. We must get that tube down, the patient must have their drugs, from families to nurses, but my mum's going to starve if you don't get that tube down her. And it's quite scary for a band 5 staff nurse on a busy medical ward to have that sort of pressure. Not only nutrition nurses worried, but staff nurses, doctors are worried. It's talked about from the perspective of very experienced nutrition nurse specialists not knowing the best way to train staff because they're not getting the support from trust boards. The nurses know they could follow guidance to the letter, do everything that's written down that goes what the NPSA alert of 2011 said. It's got a whole list of things you should and you shouldn't do. You can still be looking at a never event. And they need to feel that they're supported. They need to feel they're supported by their senior colleagues, and they need to know they're supported by trust board at board level.
I didn't like it to begin with. I didn't want it in. Very nervous, worried, and obviously didn't know what to expect to begin with. But once it was done, I was completely fine and trying to get used to having something different there. I know it can go wrong, but you still have to put the faith in with the doctors or nurses.
With the NG, because it comes across as such a minor thing, I've got the knowledge and I know that actually it can be very dangerous, but I don't think everyone is aware that it can, cause problems. But I think it is really important that the patients are made aware as well as the staff of what the procedures are, so that they can question it and ask if they're able to, and if they're not, that's actually, they're safe in the knowledge that it all has been followed.
We need to get more doctors on board, and I'm not talking about specialists, I'm talking about your junior doctors who work in various teams. They need to be on board with how to pass NG tubes, how to read accurately the tip, where the tip is, and when it is appropriate or not appropriate, because sadly a lot of nasogastric feeding tubes that are passed are on people that perhaps it isn't the most appropriate decision. This will provide a framework to train colleagues to be as safe as they can within the parameters that we've got at the moment. It has been peer reviewed by very experienced nurses and consultant gastroenterologists.
It's a very multidisciplinary group that can call upon the different professions in order to try and find the answers. What we really need to do is find the ideal methods. We need to incorporate new technologies. We need to improve on various protocols. And I think that's where BAPEN has a chance to be able to try and pull this all together.
Policies and procedures in any organisations can be very lengthy and wordy documents that tick a policies and procedures box, but that doesn't necessarily equate to having user-friendly documents that can be used at a ward level, a quick reference guide, something that people can dip in and out of very easily to support the safe care of patients. And that's what's desperately needed.